All right, guys, we're going to get started. Can everybody hear me? Is this picking up? Yeah, okay. So I'm Emily Gilbert. I'm one of the pulmonary critical care attendings, and I am also the physician lead on the sepsis committee. So I have been doing this talk for several years now. I give this talk a whole lot, and so I did try to go through the literature that's been published in the past couple years and update this talk so you guys are up to date on kind of everything that's going on in the world of sepsis. In the past, when I've given this lecture, Laura Ozark, who listened to it, said it was good, but I went way too fast. So I rely on you guys to give me some sort of signal. If it's too fast, I try to get through a lot of information. So, and Matt told me I had 45 minutes, and that's it. So let's get started. All right, so I start by just showing a very, very brief pathophys slide to emphasize that the way that we react to sepsis really depends on a lot of different factors, right? So the host factors, how old you are, what meds you're on, how sick you are, and also pathogen factors, the load of the pathogen, the virulence, etc. There are two things that happen. There's a pro-inflammatory response and an anti-inflammatory response. The anti-inflammatory response is there to balance the pro-inflammatory response. And anything that tips the balance either way in kind of the wrong direction can lead to death. So how one person responds and to an infection may just develop sepsis, whereas if there's too much of a tip in the balance in one way or the other, that patient can develop severe sepsis or septic shock leading to death. So let's talk about the definitions. You guys know that there are a couple definitions out there these days, right? These are the definitions, these are the old definitions that we still use here at Loyola. This is what LUMC uses, Trinity uses, which is our parent organization, and CMS, which is the Center for Medicare and Medicaid Services. So this is the SIRS criteria, which we all know and love, right? You have to have 2 or more SIRS criteria, plus a suspected or documented infection, and that's sepsis. If there's evidence of end organ hypoperfusion, like an elevated lactate, new need for non-invasive or intubation, then that would be end organ hypoperfusion indicating severe sepsis. And then septic shock, of course, is if you are hypotensive, not responding to fluids, or your lactate is over 4. This is why Kevin Simpson created the saying over 4 must pour, and you'll understand what that is in a second, but lactate over 4 is very bad and indicates septic shock, and they should be treated as such. So these are the definitions that we use here at Loyola. But the problem with these definitions is that SIRS is very poorly specific, right? You run up a flight of stairs, you meet SIRS criteria. You have AFib with RVR, you meet SIRS criteria. It is not specific for sepsis, and that's what really a lot of people have an issue with. So then these new definitions came out in 2016. These are called the Sepsis 3 definitions. And the authors really wanted to emphasize several points. First one, sepsis is not infection plus 2 or more SIRS criteria. A lot more goes into it than that. And the host response to that infection is really important. They wanted to really identify those patients who are at highest risk for death. And those are the people that develop end organ dysfunction, the severe sepsis, although they eliminated severe sepsis, saying that all sepsis is severe. So what they wanted to do is find a way to take all the infected patients in the hospital and pick out the ones that are at the highest risk for death. They did not study criteria for infection. They did not want to come up with a new SIRS criteria. And they did not want to build an alert or a sniffer among non-infected patients to find the infected patients. This is not what this paper was about. It was about identifying the sickest of the infected patients. So this is their new definition. Sepsis is now a dysregulated host response to infection leading to end organ dysfunction. And the way they measure end organ dysfunction is using SOFA criteria, which you can see here. I don't use SOFA a lot. It's used a lot in research purposes, but they liked it because it really took into account most of the causes of organ dysfunction that we worry about. Septic shock is sepsis plus hypotension that is unresponsive to fluids, requiring pressors with a lactate over 2. That's it. These are the only definitions that they presented. So SOFA score is good at predicting mortality in the ICU setting, but they wanted to come up with a way to try to predict the sickest patients on the wards. And that's why they came up with QSOFA. Again, the QSOFA is not a new SIRS criteria. It is a way to say, okay, this is an infected patient. Are they at risk for death? And so they said, okay, we'll use this QSOFA, respiratory rate greater than 22, altered mental status, and systolic blood pressure less than 100. If a patient meets 2 or more of these criteria, they're probably somebody that is at risk for death and that we should watch them a little bit closer. And when they compared, Q-SOFA to other kind of different scales, they found that Q-SOFA performed just as good as an organ dysfunction scale and better than SOFA and SIRS at predicting mortality on the wards. But the problem with Q-SOFA, so SIRS is not very specific, Q-SOFA is not very sensitive. If you wait for your patient to meet 2 or more Q-SOFA criteria, they potentially could be very, very sick. Only 20% of patients who are admitted to an ICU will meet Q-SOFA criteria. So if SIRS isn't specific and Q-SOFA isn't sensitive, then what can we use? Well, here at Loyola, we use the Modified Early Warning System, or warning score, or MUSE. This runs continuously in the background of EPIC and calculates a score every time a patient has a new vital sign or level of consciousness entered. So you can see if somebody has a fever, they're tachycardic, and they're tachypnic, they would have a high MUSE score. Now, MUSE does not equal sepsis. A lot of the nurses have confusion about this. If there's a positive MUSE, that does not automatically mean the patient is septic. They could have AFib with RVR, they could be withdrawing from alcohol, but it does indicate that your patient is potentially clinically deteriorating. So what we did to try to improve the MUSE to be more specific for sepsis is we introduced a nurse screening tool. The nurses will answer these 3 questions at the change of shift and any time a MUSE is 4 or greater. Do you suspect a new or worsening infection? Is there a change in mental status? And is the MUSE greater than 4? If the answer to question 1 is yes, and the answer to question 2 or 3 is yes, then that is a positive sepsis screen. And the nurse is then prompted to start the sepsis clock, saying, okay, I think this patient is clinically deteriorating. I think that deterioration is due to sepsis. So I'm going to start the sepsis clock and say, I'm going to call this time 0. This is my time 0 where I should start taking care of the patient more aggressively for their sepsis. Now, if the answer to that first question is no, they do not think that there's new or worsening infection, then that MUSE score is probably not due to sepsis. It's due to something else. And they do not need to start the sepsis clock. So when the nurse starts the sepsis clock, she's instructed to call the primary team and call a rapid response if the patient is on the floor. The clock can be started by the nurse or the doctor, but the clock can only be stopped by the doctor. So if a nurse calls you and says, hey, I started the clock on your patient, I think they're septic, you can be like, no. They came in septic a couple days ago, we've been treating them, this is fine, go in and stop the sepsis clock. On the other hand, if you think the patient is not even septic at all, and in fact withdrawing from alcohol, go in and stop the sepsis clock. If you keep it going, you'll find out why this is not ideal, but it's really important to stop the clock if you don't think the patient is septic and that's their time 0. And to find the sepsis clock, it's in the sepsis navigator under the navigator panel. So how does the MUSE perform? This is a paper that was published recently which compared SIRS to Q-SOFA to the MUSE, and they found that MUSE was better at predicting mortality than Q-SOFA and SIRS. So although a lot of you probably think that MUSE is put in place to ruin your life, it's actually shown to be good at predicting those deteriorating patients. So that's why we use it. So once you are called with a sepsis clock and you're like, wow, that patient really is getting sicker, I am going to start treating them for sepsis, how do you manage it? We cannot talk about the management of sepsis without talking about this paper. This is the paper that we've all seen a million times. This is the Dr. Rivers early goal-directed therapy trial that was published now 17 years ago. And what he did was he said, okay, you know what? I think that we're managing sepsis all wrong. I think this is a medical emergency. We need to take care of these patients quickly, urgently, and aggressively. So he took septic shock patients and he divided them into usual care or intervention. His usual care, he intubated them, he started them on pressors, he put them on a central line, he monitored their CVP and their MAP. But in his intervention group, he did something different. He did a special central line with a mixed venous O2 sat monitor on the tip, and he monitored their SpO2 continuously. And he said, okay, after I've given them fluids and I've given them pressors, if their SpO2 is still less than 70%, then I don't think my organs are getting the oxygen they need. I need to do something better. So I'm going to transfuse them to a hematocrit of 30, and if it's still less than 70, I'm going to start them on dobutamine to improve my oxygen delivery. And what he found was that his control group, half of them died, which is really high even back then, But his intervention group, where all he did was monitor that SpO2, had a 30% mortality. So a 15% absolute reduction in mortality, which was huge. Everything changed after this paper came out. I remember when I was a resident, we had a poster in our ER with this exact protocol. We all followed it. But there was a lot of controversy about this paper, mainly that maybe his control group mortality was way too high. And so it was repeated, right, 3 times in 2014, Process, Arise, and Promise, where they compared usual care, and now this is usual care in 2014, and then compared it to the Manny-Rivers protocol, which, as you all know, showed no difference in mortality when comparing usual care to his exact early goal-directed therapy trial. And then this came out last year, the PRISM analysis, which was a prospectively planned meta-analysis. They pooled all the data from Process, Promise, and Arise to eliminate any sort of trial-specific effect, and they found the same thing, no difference in mortality. Now, Dr. Rivers will say, but your patients weren't as sick as my patients. And so what they did was they did a subgroup analysis, and even in the sickest patients, there was no difference in mortality between usual care and early goal-directed therapy. But before patients were even randomized to the usual care versus early goal-directed therapy, they were treated for their sepsis. They got fluids, they got antibiotics. And if you look, most of these patients had normalization of their mixed venous O2 sat before they were even randomized. So Dr. Rivers will say, well, you already treated them. Of course, that's why there's no difference. So say what you will about the early goal-directed therapy protocol, it's important to mention that this paper is still being talked about 16 years later. He changed the way that we manage sepsis. He's the reason that usual care is not what usual care was back in 2001. So it is important to say, even though the early goal-directed therapy trial protocol we don't follow anymore, he really did recognize that sepsis was a medical emergency, and I think that's really important to remember. So after Promise, Process, and Arise came out, the new SEP1 bundle came out and went into effect October 1st, 2015. And these, again, this sepsis is a medical emergency, right? Just like MI, just like stroke, you need to start treating these patients urgently. And so that's why there is a 3-hour and a 6-hour bundle. And this bundle should be started as soon as you recognize the patient is in severe sepsis or septic shock. So 2 or more SIRS criteria, suspicion for infection, end organ hypoperfusion. The second that all 3 of those things are present, your clock starts and you got to complete this bundle within 3 hours. So blood cultures, antibiotics, lactate, and a fluid bolus for hypotension or lactate over 4. If you are not hypotensive and your lactate is 3.9, you are not required to receive the fluid bolus. Important to remember. The 6-hour bundle, not as important. We'll talk about that later. So let's talk about the data behind all of these bundle components. Cultures, no-brainer. Get blood culture so you can try to identify your pathogen. Antibiotics, this has been looked at in a bunch of different studies. This is the most recent one. This is a huge study that was performed by Chris Seymour in New York City. Huge number of patients. And what he found was that the sooner you complete the bundle, the lower your mortality. But when you break down what bundle component it is that leads to that decrease in mortality, it's the antibiotics, not the fluids. So this just goes to show that even delaying 1 hour in giving antibiotics, your mortality goes up. So if you take away one thing from this talk and just go to sleep the rest of the time, give antibiotics anytime you suspect infection. Order them stat, make sure they're given, talk to the nurse, be like, I ordered cefepime and Vanc, please give them, please give them. Did you give the cefepime and Vanc? It's so important for mortality. It's the only thing that's been shown to decrease mortality is giving antibiotics quickly. So what do we do here at Loyola? We actually do okay. 90% of our septic patients receive antibiotics within 3 hours. Ideally, they get it within 1 hour. Like I showed, every hour you delay, your mortality goes up. But at least they get it within 3 hours. Cephalosporin, Zosyn, Aztreonam, the classic kind of broad spectrum antibiotics are all IV push now. So nurses, you order it, the nurses will get it and push it over 5 minutes and then it's in. Remember that these should be given before vancomycin because vancomycin has to be given over an hour. And if the vancomycin is delayed and then the vancomycin has to go in over an hour, then you might be out of that window. So make sure that these are given first and then you can hang your vanco. If you order antibiotics through the sepsis order set, it's great, right? So you're like, I think my patient has HCAP, You go to HCAP, you click on the button, it comes up with all your antibiotic choices. You order them through there. They get ordered as stat. You don't have to call for ID approval. It's wonderful. So please order your antibiotics through the inpatient sepsis order set. You get them for free. Please use it. So that's what we've done here at Loyola, and we're actually getting better and better at getting our antibiotics in quickly. Serum lactate, there are a lot of things that cause lactic acidosis, most common being shock, any type of shock. But of course, the type B lactic acidosis, which is due to like leukemia, lymphoma, some of the meds that we use in the ICU, like epinephrine, albuterol, these can all cause a lactic acidosis. But if your lactic acidosis is due to sepsis, then the higher lactate, the higher mortality. That has been shown in multiple studies. Here's an older one, here's a more recent one, where it shows that no matter where you are, ward, ICU, or ER, your lactate goes up, your mortality goes up. I find lactate helpful because it helps me determine how sick the patient is. And then I check another one in a couple hours to see if what I'm doing is making them better, right? So if I check a lactate in at 6, I'm like, wow, that's a sick patient. I give them fluids, antibiotics, pressors, etc. And I check another one several hours later, and it's down to 1, then I'm doing a good job. But if I check it in at 6 and later it's 12, well, I don't think that patient is going to survive, and then I talk to the family and maybe change how I'm managing that patient. So it is helpful as a prognostic marker and also telling me how we're doing in terms of managing that patient. Okay, the 30 cc's per kilo IV fluid bolus. Very controversial, as you guys know, especially here at Loyola. We have a lot of patients who don't tolerate fluids, right? Like the LVAD patients, like our pulmonary hypertension patients, some of our transplant patients. But remember, it only needs to be given if you're hypotensive or your lactate's over 4. If they're not hypotensive and their lactate's not over 4, you don't have to give them the bolus. Remember that. So where did this whole 30 cc per kilo fluid bolus come from? So here's the Rivers protocol, where the people in his intervention group got more fluids than the control group, and you can see mortality went down. Was it the fluids? Was it the antibiotics? Was it the SVO2? What made that mortality go down? But after this came out, people were like, well, we should probably give more fluids. So they did, and these are all observational studies, and you can see that in the early goal-directed therapy group, mortality is down, fluids are up. But again, is it the fluids or is it the early antibiotics that's improving mortality, right? This is PROMISE, PROCESS, and ARISE, where you can see no difference in fluid, no difference in mortality. So you can't really comment on anything from those studies. So on the one hand, so that's why we started doing a lot of fluids back in the early 2000s. And I will say, most patients who are septic need fluids, okay? They are vomiting, they're febrile, they're having diarrhea, they're third spacing, they have capillary leak, they're empty, and they need some fluids. Now, do they need 30 cc's per kilo? Maybe. I would probably need 50 cc's per kilo. I'm young-ish. I have a good heart. If I come in with massive diarrhea and vomiting, please give me more than 30 cc's per kilo, which is literally like, right, 2 liters. Nothing. That's like nothing. But if you have like a 95-year-old woman who has severe AS, who you can't intubate, then maybe that one you want to be a little bit more gentle. So it's hard to say that everybody needs 30 cc's per kilo. So on the one hand, yes, people need fluids, but on the other hand, too much fluid can lead to a lot of complications, right? Like there's been multiple studies that show the more fluid you have on board, the longer you're on the ventilator, the longer you're in the ICU, the higher your mortality. There's a lot of complications from fluid overload. So when researching this talk, I found an interesting paper called the 4 Ds of fluid therapy, similar to the 4 Ds of antibiotic therapy, where you have to think about the drug you use, the dosing, how long you're going to use it, and then de-escalation. So let's talk about each of these. So first, drug. The crystalloid colloid kind of debate has, I think, been put to rest. We use crystalloid. But now the question is, do we use saline or balanced crystalloids? And balanced crystalloids are plasmolite and LR. So there have been a bunch of trials looking at this, and really what we should take away is that normal saline in excess, so a ton of normal saline is bad, right? It causes hypernatremia, hyperchloremic metabolic acidosis, it can cause AKI, but does that mean that we should be using LR for everybody? There's been a couple trials that look at this, most recently the SMART trial that came out this year in the New England Journal, where it compared saline to LR or plasmolite for critically ill adults. And what they will say from this paper is that the balanced crystalloids, or LR or plasmolite, is better because it had decreased rate of the composite outcome of death, new need for hemodialysis, or persistent renal dysfunction. But if you look at those all individually, they actually, the p-value is very, very subtle. It's like 0.04. It's like 15% versus 14%. So the difference is when you look at the actual numbers are not that impressive. But when you look at the subgroup analysis, you can see that actually balanced crystalloids are better in certain populations, people who have needed dialysis in the past and people who are septic. Interesting. So I don't know if this is going to change my management. I think if somebody needs a couple liters, it doesn't matter what you give. Normal saline, LR, or plasma-lyte, it's fine. But if somebody needs to be aggressively fluid resuscitated, multiple liters, then maybe LR is better, especially in those with AKI, previous need for dialysis, or even sepsis. So something to think about. So dosing, is 30 cc's per kilo for everyone? No, right? We just talked about how one size does not fit all. And so there was an interesting paper that came out. Did anybody see this? This is interesting. So 2017 in JAMA, where they said, okay, we're going to take and we're going to implement a sepsis protocol in Zambia, Africa. And so usual care was basically give them antibiotics, give them IV fluids if you think they need them. Sepsis protocol was 2 liters over an hour and then another 2 liters over the next 4 hours. And what they found was that the people who got the sepsis protocol had a much higher mortality. And that's because these patients are not like the patients we typically see here in the US. Most of them have AIDS. Most of them weren't walking because they were so weak and deconditioned and sick. And most of them were young. So it just goes to show that one protocol, one dose, one amount of fluids does not work for everyone. This is a paper that came out recently looking at the evidence behind the 30 cc per kilo fluid bolus and basically showed that all the papers that support the 30 cc's per kilo fluid bolus had a high amount of bias and a high amount of confounding, meaning that none of them just got the bolus. They got like the bolus and early antibiotics. So how can you say it was the bolus that led to a lower mortality? So this was a very interesting paper that caused a lot of anger from the surviving sepsis team. So interesting paper if anybody wants to look at it. There are a couple trials coming out right now. There's the Refresh trial and the Clovers trial that is doing a liberal versus restrictive fluid randomized control trial for sepsis. But people are still getting initial fluids. It's not like they're saying, okay, you're septic, you get no fluids, you get a lot of fluids. They're basically giving everybody about 1 to 3 liters and then randomizing them into no more fluids, start pressors versus just more fluids. So those two are ongoing right now, so it'll be interesting to see what they come up with. So the duration and the timing of the bolus, it's really the timing that I'm more interested in. And if you remember, this is the paper by Chris Seymour where he showed that earlier antibiotics lead to lower mortality. This is what his fluid graph looks like. This is the timing to completion of the fluid bolus, and you can see absolutely no difference in mortality based on the time that you complete the fluid bolus. Interestingly, this paper was published from the same group of hospitals. So same hospitals, different outcome. So a lot of the patients probably overlapped in these two studies. And so what they were looking at is the time to initiation of the fluid bolus. And they found that if you start it earlier, maybe there is an improvement in mortality. So that brings up this whole thing is there this golden 2 hours or 1 hour of resuscitation? Meaning, if you start the fluids early enough, maybe they hold on to them longer. Maybe they have a better effect because there's not as much capillary leak and not as much inflammation yet. And kind of along those lines, this is an interesting paper that gave 2 liters of LR to different types of patients. So you can see if you give 2 liters of LR to a conscious volunteer, you get a pretty minimal increase in your plasma volume that goes back to normal over time. But if you give 2 liters of LR to somebody in hypovolemic shock, you have a dramatic increase in your volume that kind of sticks around for a lot longer. So it really, how well your fluid bolus will last really depends on the clinical scenario and maybe the timing. Maybe if you give it earlier, you have a better effect. So something to think about. And then the final D is de-escalation. What I like to do is when the patient is off pressors for about 24 hours, I start to diurese them. Because there's multiple studies that show the higher your fluid balance, the higher your risk of mortality. And that is an independent risk factor. But what at which point do you say the fluid balance is an independent risk factor? This is a paper that was published last year that showed it's not your fluid balance at 24 hours, it's your higher fluid balance at 72 that predicts mortality. And maybe that's because people who are still in shock and still have a positive fluid balance at 72 hours, those are the people who are going to die, more likely to die, rather than those who are in shock for about 24 hours and then you can start diuresing them sooner. So like I said, what I like to do is I like to resuscitate them, start them on pressors if needed, and really whatever resuscitation endpoint you want. Do you want to look at SVO2? Do you want to look at lactate clearance? Or do you just want to look at improvement in the patient? Are they off pressors? Is their MAP better? Are they peeing? Are they waking up? And then once you show that they're stable off pressors and their blood pressure can tolerate it, start diuresing them. And that's what I do. So kind of to summarize, that was a lot of slides on fluids just because I know it's a pretty controversial part of the bundle. In terms of the drug, LR probably preferred in those patients with a history of AKI or renal disease, but if you're just giving a couple liters, normal saline is probably fine. Dosing 30 cc's per kilo, probably not enough for me or you if you got septic, probably too much for somebody who is profoundly volume overloaded to begin with, or severe AS or a DNR DNI. So really use your clinical judgment. Even though this is what is stated in the bundle, you're not going to get fired, you're not going to get in trouble if you don't use the 30 cc's per kilo fluid bolus because you think it'll make the patient worse. So that's okay. Duration, maybe we should start fluids earlier. Maybe, maybe that whole golden 2 hours of resuscitation does exist, and if we started earlier, it'll have a better effect, rather than just seeping out into their tissues. And then de-escalation, Lasix when the shock has resolved. So that's the 3-hour bundle. The 6-hour bundle, not as important, certainly will not affect mortality, but like I said, I like to repeat the lactate if it was over 2, just to see how I'm doing. If the patient is in septic shock, so persistent hypotension or a lactate over 4, there needs to be a note in the chart documenting that you went back and evaluated your patient. You should be doing this anyway, but the government wants proof that you've done it. So you need to basically go back and say, I saw the patient and they're fine. We used to have a .6 note where we had to have very specific things in the note to show that you went back and saw the patient, but we don't do this anymore. All you have to do now is say sepsis exam done. That can be alone in a progress note, that can be in your H&P, but anybody who's in septic shock needs to have this note in the chart within 6 hours of time 0. This we do not do well on here at Loyola. We forget this most of the time, but maybe now you'll remember. And then the final part of the bundle is pressors. Am I going too fast? Am I okay? Okay. So pressors. This is the Surviving Sepsis Campaign recommendation for pressors. First line pressor is always Levophed. I always say that when I was a resident, we never used Levophed. We called it Levophed, leave them dead. And now it's our first line pressor. It's wonderful now. So Levophed is our first choice vasopressor. Our second line is epinephrine or vasopressin. We use mostly vasopressin here at Loyola, but if there was a vasopressin shortage, epi is a great pressor. Dopamine we rarely use. I only use it in my patients who have relative or absolute bradycardia. Phenylephrine. I do not like phenylephrine, and I will tell you why. So phenylephrine is a pure alpha agonist, right? It binds to alpha receptors. You have increase in your SVR because it causes vasoconstriction, which is fine because hypotension is the primary problem in sepsis. However, about 14% of septic patients have what's called septic myocardial depression, sepsis-induced cardiomyopathy. It is a cytokine-driven process. It's one of the complications of sepsis. And these patients will be shifted down and to the right on the Starling curve and act everything like CHF. And so if you get an echo on your septic patients and their EF is down and you look at the troponin and it's flat and you don't think they've had an MI, then maybe it's this. It gets better in about 7 to 10 days, but this is a real problem. And so that's why I don't like Neo, because if you have pure alpha, it does nothing to help the heart, right? Levophed and epinephrine bind to beta-1 receptors. Beta-1 causes contractility and can help these patients with this sepsis-induced cardiomyopathy. So that is why I don't really like Neo so much. The other thing I see people using Neo for is if Levophed is causing tachycardia. What I usually see is if somebody's tachycardic on Levophed, it's not from the Levophed, it's because they're really, really sick. And if you switch them to Neo, they're still pretty tachycardic. So I usually leave them on Levophed unless they're having like life-threatening arrhythmias like VT. Then I'll switch them off the Levophed. But other than that, I like Levophed better than Neo. Oh, and the risk factors for the sepsis-induced cardiomyopathy, younger age, higher lactate, and a history of heart failure. So vasopressin, again, we love vasopressin here. I love vasopressin. I think it's really, really helpful in getting the Levophed dose down. The reason that we use vasopressin is because there's thought to be a relative vasopressin deficiency in septic shock. There's been multiple trials looking at vasopressin to see if it improves mortality. This is just one of them. This is the VAST trial from 2008. No difference in mortality, but the reason that we use it is because it allows that lower dose of Levophed, and therefore there's less arrhythmias. So decreased risk of atrial fibrillation. But again, no significant difference in mortality, and this is based on a new meta-analysis of all the old papers. So tapering pressors. This is an interesting study that I found, because when I was a resident, what we did was we started Levophed, and then we started the vasopressin, and then once the patient was stable, we turned off the vasopressin and then started tapering the Levophed. But when I became a fellow here, it was the reverse. They did Levophed, vasopressin, and then turned off the Levophed first, and then turned off the vasopressin. And that was based on 2 retrospective studies in 2010 and 2017 that showed if you did it that way, it was better, less hypotension. But this was a randomized controlled trial that came out just this year, where they started people on Levo and Vaso, and once they were stable, they randomized the patients into which vasopressor they titrated first. And you can see if they turned off the Levophed first, a lot of the patients became hypotensive, versus if you turned off the vasopressin first. And that makes sense, right? You can you don't taper vasopressin. You turn it on, you turn it off. And so, whereas norepinephrine, you can taper. So I think I might be going back to this, where I turn off the vasopressin first and then work on titrating the Levophed, just based on this paper. It was interesting. Okay, other therapies. Steroids. This has been a hot topic this year, right? So steroids in sepsis is really kind of counterintuitive. Why would I give a whole bunch of steroids to somebody whose infection is so profound that they're in septic shock? It's because if you think about it, right, again, going back to that pro-inflammatory response and the anti-inflammatory response, a lot of times what leads to the end organ dysfunction in septic shock is too much pro-inflammatory response. And so the steroids can help depress that pro-inflammation and maybe improve your mortality, maybe improve your ability to come off pressors. So this was the Corticus trial that was published in 2008, which showed actually no difference in mortality between those patients who were in septic shock on placebo versus steroids. And then this year, 2 new papers have come out. This is the adrenal trial, and this is the approaches trial. And the adrenal trial, again, showed no difference in mortality. But the approaches trial did show a difference in mortality, which was shocking, right? Because nobody in critical care literature shows a mortality benefit ever. And if they do, we don't believe it, right? And so this was really, really shocking. So let's look at the differences between these studies. So number 1, if you look at the mortality, right? So here's Corticus, 36 versus 39, no difference. Here's adrenal, 29 versus 28, no difference. But the approaches trial had a really high mortality, and they did see a difference. So maybe it's that their patients were sicker, right? If you're the sickest patient, maybe you do benefit from steroids. So then let's look at see how sick they are. It's hard to compare adrenal and approaches because they used a different way of grading their sick patients. Whereas approaches use SOFA, the adrenal used Apache. But both numbers are really high, so these patients are really sick, and similar to Corticus, right, which had a SOFA score of 10.6. So maybe their patients were sicker. The other difference is what the meds were, right? So Corticus gave hydrocortisone 50q6. Approaches did in a continuous infusion, so they never got a bolus of steroids, so maybe that's why they didn't notice a difference in mortality. And then the approaches added fludrocortisone. It's such a tiny dose. I doubt that actually did anything, and it's certainly not the cause for the change for the decrease in mortality. So it's interesting that approaches did show an improvement in mortality, but what all 3 studies did show is that if you were on steroids, you come off pressors sooner. You were out of shock sooner. That Corticus showed that, approaches showed that, and adrenal showed that. Corticus didn't look at time to weaning from mechanical ventilation, but approaches and adrenal did, and both of them showed that if you were on steroids, you were off the vent sooner as well. So what do I take away from these 3 trials, really, is that there's probably no difference in mortality, but I am going to still start steroids on my sickest patients. And that's what we already do, right? We say we start pressors. If we're adding a second pressor and now we're reaching for a third pressor, that's usually when I start them on steroids. I'm not going to do fludrocortisone. I really think that that made a minimal difference. I'm still going to do the 50 Q6 of IV hydrocortisone. We know that it gets you out of shock sooner, and now it's showing us that it gets us off the ventilator sooner too. So I don't think it's going to change what I do. It's just going to kind of support what I already do, which is great. And then, of course, we can't not talk about this paper. This is the Paul Merrick trial for vitamin C. Very interesting. It was a before and after study. So this is what he did. He had 3 patients that he said were destined to die of septic shock. And he's like, well, you know, I know that sepsis consumes vitamin C, and you need vitamin C to make epinephrine and cortisol. So why don't I just give them a whole bunch of vitamin C and see what happens? So he did, and all 3 of these people who were destined to die, they survived. So then he said, well, I'm going to start this protocol where I'm going to give IV vitamin C, 1.5 grams Q6, which is a huge dose of vitamin C. I'm going to do hydrocortisone, which we already do anyway. And then he gave them thiamine because high-dose vitamin C can cause renal insufficiency, so the thiamine is supposed to help with that. And he did a before and after. So he compared the patients that he did the protocol on between January and July to patients that did not get the protocol. Same number of patients, 47 in each group, all with septic shock. And what he found was that his mortality dropped from 40% to 8%, which is a huge, huge, huge reduction in mortality, as you all know. You all can do math. So, but it's almost too good to be true, right? 8% septic shock mortality is unheard of. So, oh. Sorry. Okay, so this is very interesting. It's very intriguing. A lot of hospitals are doing this protocol already. Probably a lot of the interns came from places where they're doing this protocol already. I don't do it. I don't think any of my colleagues do it that I know of, because this is not a randomized controlled trial. How do you know that he didn't like pick and choose his septic shock patients? He's like, oh God, that guy is totally going to die. I'm not going to give him this protocol. Oh, that guy, he's looking okay. I think I'll give, you know, like, how do you know he didn't do that? So until there's a randomized controlled trial, which there are some ongoing right now. As soon as this came out, everybody freaked out. So this is interesting. I'm going to keep my eye out for these studies. And maybe if it does show a significant benefit, then for sure I will do this. But until I see a randomized controlled trial, I'm going to hold off for now. Okay, finally, our compliance data and mortality. So remember I talked about that sepsis clock and how you need to stop it if it's not sepsis? This is why. Because once that clock is started, that's how we generate our bundle compliance data. So anytime a clock is started, a program runs and looks in the chart to make sure that the blood cultures and the lactate and the antibiotics were ordered. And then this form is generated. So you can see here, for like this patient, here's your sepsis start clock. Blood cultures are required, they were completed, so there's 0 opportunities for improvement. But here, oh, the blood pressure needed to be checked 2 times after the fluid bolus was done. It was required, it wasn't done. That's an opportunity for improvement. So that's what these forms look like. These forms go to the resident taking care of the patient, the attending, the nurse manager, the unit medical director, and me. So that we get to see how people are doing in terms of the bundle compliance. You get one of these forms, it's not yelling at you. It's not telling you're a bad doctor. It's just saying that we are watching how well we do with bundle compliance, and that you forgot to write the sepsis note, and maybe you can remember to do that next time on your patient. We're not yelling at you. It's just a little reminder. When you look at our sepsis severity here at Loyola, we have a lot of simple sepsis, but we also have a lot of septic shock, and that's what makes us different from the other hospitals in our organization, which is Trinity. We have a lot more septic shock than other hospitals do. We have a sicker patient population. And if you look at our mortality,